Hello, good evening, everyone. This is Dr. N.H. Krishna, founder, chairman, trustee of Chest Council of India. I think you're all aware of the fact that whenever the media writes regarding or it shows that the wave is coming, maybe the first wave, second wave, third wave, fourth wave, we doctors are bombarded by questions. The media does its job and goes away. Then we doctors are bombarded with questions by our surrounding people, our relatives, our neighborhood, our patients that, sir, we heard this, that the fourth wave is coming. Is it coming really? Will it be critical? Will there be a lockdown again? Will it take so many patients as admissions? Will it have a lot of death to follow? These are layman questions. They will come to us. They are also bothered that the economy will go down once the lockdown will happen. And they're also bothered that they may lose more of their near and dear ones, what happened with the second wave. So many people are asking us questions. And what is the answer we are giving to them? Probably we know as much as they do. So Chest Council of India decided that we will do a dissection of this. And who else here to do that job? The Raja himself, Raja Dhar. He's the moderator today. Raja Bhai is Director and HOD of Department of Pulmonology, CK Birla Hospitals, Kolkata. So he'll be moderating today. Actually, I should not share this with you people. Raja Bhai slept yesterday at 3 a.m. preparing all these. He referred all these articles. He prepared questions. He prepared slides. That shows the involvement of Raja Dhar. Wherever he goes, he provides 100% justice to that particular task. Now, when you have someone like Dr. Raja Dhar, the panel should be equally brilliant. There are two categories of people in the world, they tell. One category, which is not applicable to Chest Council of India, one category who are good at webinars, but they do not see any patients. The other category who see patients, they do not do any webinar. But Chest Council of India is not like that. We have come out with such people over here. For example, Dr. Ravi Dosi from Indore, Dr. Narayana Pradeep from Kasaragod, Dr. Nitin Abhyankar from Pune, Dr. Raja Dhar from Kolkata, our own webinar coordinator, Vijay Kumar Chennamchetty from Hyderabad, they all together must have seen more than 1 lakh COVID cases. So they will be speaking here what they have done. It is not just a webinar that they will preach. So that saying goes wrong in Chest Council of India, that who does a webinar is not someone to treat the patients. We have brought that panel over here who have treated thousands and thousands of patients and also in the webinar. So as I told you earlier, Dr. Ravi Dosi, our CCI National General Secretary, is a consultant pulmonologist, HOD of Department of Respiratory Medicine, SIMS, Indore. He is here. He is pride of the nation. During COVID, he even received phone call from the Prime Minister of India and the Chief Minister of Madhya Pradesh for his excellent work. We have our Dr. Narayana Pradeep here, who is the CCA founder trustee, co-founder trustee along with me, who treated thousands of COVID cases in all the waves that happened. And there was a separate model called Kasaragod model also, which went with the name of Kasaragod regarding the treatment of COVID. Dr. Vijay Kumar Chennamchetty, he is my sweetheart, my dear Tamudu. He is here today, and he is the senior pulmonologist at the Department of Pulmonary Medicine, Apollo Health City in Hyderabad. He also happens to be our CCI webinar coordinator. Last but not the least, we could do our 4th national conference CCI only at Pune. That was 2 years ago. And our Nitin Abhyankar Bhai, being the organizing secretary, conducted it so very well that there is a huge task coming up to Vijay Kumar to do the 5th CCI at Hyderabad. Vijay will have to break the record of Nitin, and Nitin Bhai will help breaking him that record. Our Nitin Bhai, thank you, Nitin Bhai. Our Nitin Bhai is at Pune Hospital, Pune. He is a well-known pulmonologist across the nation. He also happens to be our CCI Maharashtra state head. So when we have such a wonderful panel, What else to look after? We will go ahead straight with the panelists. All the best. Take care. I'm very sure that a very good message will come out at the end. If possible, I will try dropping in at the end. Best wishes. Go ahead. The floor is yours.
Thank you, Krishna Bhai.
Thank you very much, Krishna Bhai. Obliged for those introductions. It's absolute pleasure to be here today. And I wanted to thank Krishna Bhai and the rest of the CCI members who've actually conceived of this topic, because I think myself and everyone else on the panel actually learned a lot in the process of finding out about what the future holds for COVID. So what I'm going to do over the next 17 to 18 minutes is to talk a little bit about my thought process based on a review of literature as to what the future holds. I'm not going to talk about the fourth wave, because that's what's going to come when we do the panel discussion. But I'm going to put your thought process aligned with the way we feel about the way things are going today. So let me share screen. And are the slides visible to all of you? Are you sort of able to see the slides and hear me clearly?
Yes.
Yes. Thank you. So I'll start off by talking about how we conceived of this title. So this title I have stolen from a JAMA article which came out on the 25th of May. I thought it put things to explain why we think the way we do. And I think it forms the spine of what we are going to discuss today. So this after a quotation from Sir Winston Churchill, who said that now this is not the end. It's not even the beginning of the end. It is perhaps the end of the beginning. Now put this small diagram at the bottom for you to see, to put it into the perspective of COVID. So the question in front of all of us on this panel, the audience who's joined us to hear us, is where are we? When we say beginning, we mean the starting of COVID. So is it that we have reached the end of the COVID wave? Is there light at the end of the tunnel? In which case we are where the cursor says beginning of the end, or are we a bit earlier on where it says end of the beginning? So that's putting things into perspective. Whereabout on that line are we today? This triangle that you see is something that you would have done as a part of your preventive and social medicine classes, your PSM classes. This is the epidemiological Kappa triangle, and all of you would know, identify with this host, agent, and environment theory. And I would argue that this triangle holds true for COVID-19 or for any other viral illness for that matter. How does it hold true? Let me translate this into terms of COVID. So there's human, there's SARS-CoV-2, and there's the environment. That's the triangle that we are talking about, which translates into host, agent, and environment. So let's start off by talking about the human, the host. I'll start off by saying that estimates, newspaper articles mainly, but estimates say that 90% of the human Indian population of 140 crore has antibodies to the virus today. And when we say today, these are reports emanating from the end of April 2022. How do we reach this number? Let me give you a ballpark idea as to how we reach this number. So the fourth Sero survey on July 21st, which is now about 10 months ago, showed that 67% of patients had antibody, not patients, but people had antibodies. Of the total number of people surveyed, 62.2% had no vaccination, about 25% had one dose, and 13% were fully vaccinated. Now look at the implication of these numbers. These are not mere numbers to rattle through, but to think about. So if 67% of people in July 2021 had IgG antibodies to COVID-19, and if only 25% were diagnosed as COVID, and about 3% of the Indian population at the time who had suffered from diagnosed COVID and RT-PCR proven COVID, you understand the large load of undiagnosed patients with COVID-19 that the population has. So 25 plus 3 makes 28. We're saying 67% of people had antibodies in July 2021, which would basically mean that there's about somewhere between 35 to 40% of people who were never diagnosed as COVID but had the disease. This is the ICMR 4th survey, and I won't read through it, it's not relevant, but just to put the numbers into perspective, this was the best done sero survey that we had out of the 4 sero surveys done by ICMR. So the total number of individuals that were enrolled was about 30,000. 29,000 was the total number. This was the general population. And then if you looked at healthcare workers, the total number of healthcare workers who were enrolled in the other arm was about 7,250. So 29,000 on one side, 7,500 on the other side. Those were the numbers that were enrolled. Now, this is the fine print of the patient characteristics. Again, don't worry reading through the fine print. I don't think you would manage to read it even if you tried though. But I want you to concentrate where my cursor is. You heard the numbers, 29,000 of general population and 7,250 were healthcare workers. If you look at the total number of people vaccinated there, the total number of people vaccinated in this survey was about 20,000 in the general population arm and about, so it's down below, it's 7,600 in the general population and it was about 6.5 thousand in the healthcare worker arm. So if you look at the general population out of 29, 7,600 were the total number of people who were vaccinated, which is about 25%. In the healthcare worker arm, there's about 90% people who were vaccinated. Okay, so very good performance even about 10 months ago as far as vaccinating healthcare workers in India was concerned. Now, if you look at the number of people who were eventually tested and came back as positive in the general population, look at where my cursor is. About 66.7% of people had antibodies. And if you look at healthcare workers, about 85% has antibodies. So all the healthcare workers who got vaccinated had more or less got antibodies, whereas in the general population, it was only about 25% of the total number who got vaccinated, but still had antibodies. The vaccination status was patchy, and so was the seropositivity throughout the country. So in places like the capital of India, so this is East Delhi, if you look at the sampling from September, October, about 100% of the population in East Delhi had antibodies. So big cities, metros, the large cities from where we work, the seropositivity rate is very high. If you look at suburban areas, tier 3 cities, rural areas, the seropositivity was much lower. So there was patchy seropositivity throughout the country. And why is that important? When we go forward and look at further waves, it is more than likely that these waves will start off in the rural, suburban, tier 3 cities of the country rather than starting off in the big metros. However, with so much of traveling that happens to and fro from these metro cities, it might well be that the people coming from the rural and suburban areas for work would come and infect people in these cities. This is the lovely paper which came out a year ago and looked at SARS-CoV-2 seroprevalence throughout the world. I want you to focus on certain areas here. I want you to look at India. India is somewhere here with about 66% seropositivity. So that's where India lies. So that's India, where my cursor is at the moment. And you can see seropositivity of about 60% on there. If you look at places like South Africa, where my cursor is, the seropositivity is less than 50%. So if you look at viruses like Omicron, for instance, the areas where seropositivity was lower, the case burden was higher, but much more important, people got hospitalized in these areas. So places like the US, places like Germany, for instance, which is later on here, the seropositivity rate was about 30%. The caseload was higher, but more importantly, more people landed up in hospital, more people landed up in intensive care, and a small minority died. places like India, where the seropositivity was high and is high, the number of cases was far lower. And even if there were cases, they were mainly asymptomatic or mild cases. So once you have the disease, when do you actually become when do you actually get the most amount of antibodies? Till when do these antibodies last? So this is a paper which looked to answer this question. So this is people who had infection, not vaccination, but infection. And the study found that 100 days post-infection, your antibody titers kept rising. So 100 days post-infection, antibody titers kept rising, and then it dipped to the levels which were almost zero at about 500 days and beyond. So that's 1.5 years. So 1.5 years is the total antibody duration that the antibody lasts. About 9 months you have antibodies which provide you some protection, and about 100 days is when you have the antibody titers increasing. These factors vary according to age, body mass index, smoking severity, and the disease severity, whether the individual is hospitalized or not. Greater the severity, greater the antibody response that you get. So age, BMI, smoking status, and disease severity tell us till what duration of time the antibodies last in your body. In people who are vaccinated, the antibodies seem to wane beyond 20 weeks. So that's about 5 months. So remember, the antibodies that you get post-infection seem to last longer as compared to antibodies that you get post-vaccination. The vaccination antibodies lasts about 6 months, which is why the Indian diktat of giving a third dose, a booster dose at 8 to 9 months beyond an infection or beyond the last dose of vaccine. And this waning is greater in people who are in the high-risk group. So older adults and people with comorbidities, the high-risk group are people where the waning of the antibodies, the waning of immunity happens quicker. So that's about the host. That's about the human. We next come to the agent, the epidemiological triangle, remember? So we come to the agent. The agent is the SARS-CoV-2 virus, as you all know. So this is a diagram from 2020, a dated diagram, but I think it puts into perspective the various variants, the mutants that we've had during this time. So this gives you a graphical idea of the different strains and variants that we have looked at, starting from alpha, then to beta, and then to gamma. This is all through 2020. And you can see the time frame and the countries given in the diagram. The countries are the countries of origin of this particular variant or the particular mutant strain. So that's from 2020. Next, we come to 2021. And you can see added on to the 2020 list from the B1617, which is the Delta virus, got detected in India for the first time in 2021 and ravaged all of us. All of us saw deaths. We saw hospitalizations, intensive care visits, and probably all of us in the panel and the audience listening there had the worst time of their life. So the Delta virus, the mutation as you see flowing on the diagram, starting from B117 to B1617, resulted in the deadliest strain the human race has ever seen as far as viral infections are concerned. This looks at cleavage sites, and this goes to show you that minor mutations, especially mutations in the spike protein region of the SARS-CoV-2 virus, results in changes which might make the virus more aggressive, as in case of the Delta virus, or more transmissible, as in the case of Omicron. So you see where my cursor is. So gamma to Delta, the change from gamma to Delta made the virus more potent, more aggressive, more lethal. And the changes from the B1617 to Omicron, which is the B11529, that change made it more transmissible. So the mutations normally over a period of time make initially the virus more aggressive, and then with the passage of time makes the virus more transmissible, as has happened with Omicron. So high number of cases means greater chances of mutation. So you have the virus traveling from one individual to the other. The virus is making an effort to survive, and survival would mean immune escape, escaping the antibodies the individual has. And in doing that, from individual to individual, from city to city, from country to country, continent to continent, you have changes which are profound enough to enable immune escape in making the virus more transmissible. And hence, mutation leads to new variants. As I showed you in the previous slide, the virus changes in a way so that it can survive. You remember this theory about survival of the fittest. So the virus wants to be the fittest, fitter than the human being, which is why it mutates. And the scientists are most concerned about changes that happen in the new region of the spike protein. Why is that? Because spike protein is the region where the virus enters the human cell. This is a lovely diagram, which is from I won't take you through the details, but look at the basics, because this will help you to engage with us when we do the panel discussion. So we started off with alpha and delta, like we said, and we have got to Omicron, but see the three circles in the middle. First, you have increased transmissibility, and this is as a result of evolution. So evolution in making the virus more transmissible. This increased intrinsic transmissibility could be due to unreliable prior immunity. It could be due to higher incidence of infection, or potentially the low burden of disease in certain areas, resulting in more asymptomatic diseases in some populations, like we have seen in the Omicron era. Then you have immune escape, which I spoke about just now, the virus trying to change its form so that it can escape the immune system, the antibodies that the human host provides. And for immune escape, you have unreliable prior immunity, high burden in the naive or immune population, and highest need for non-pharmacological control measures like the mask, etc., to which I'll come to in a minute. And then lastly, you have disease severity, which again is an evolutionary byproduct, but this results from high disease burden, more in the initial 1 year of the disease process or 1.5 years of the disease process. And it happens more, like you see in this diagram, in people who are bedbound, who have comorbidities, and who are aged. So that's the population where disease severity matters a lot, because that's the potential population which might die from having the disease. This is a wonderful paper which came out in Science, believe me or not, 2020. And this showed potential models in how this disease will pan out over a period of time. And they discussed 3 different models, the peaks and valleys. So the peaks are the peaks that we've encountered, 1, 2, 3, and maybe 4. Then you have the fall peak. So the peak gradually falls. You can see the peak on here and the peak here, which is much lower than the first one. And the peak keeps falling. And then you have the slow burn, where the disease dies out gradually and becomes endemic over a period of time. And you understand how good these predictions are. 2020, when this disease started, this is from 2020 that this paper published, all these models have lived true to their name. We started off with having large peaks, which kept coming and going, the spike and the dips. Then you had the fall peak. So you had the delta, and then you have the Omicron, which is a smaller peak, even though the numbers are large. And then you have the slow burnout. And we hope that the 4th, 5th, and so on waves would be in the burnout phase. Last, we come to the environment, and I'll finish in the next 5 minutes. So in the environment, we know the SMS, the sanitization, the masking, and the social distancing. This shows that across the board in SARS-CoV-2, in the SARS-CoV-1 and epidemic which happened before, and the MERS, the Middle East respiratory virus epidemic that happened in the Middle East, the distance at which disease transmissibility seems to be less than 5% is 2 meters. So distance of 2 meters that came out from the study that you have in front of you. What about the mask? And this shows that the face mask use causes a large reduction in the transmission of infection, and is probably the single most important predictor after vaccination, in reducing the transmission of infection. And you need to remember this when we discuss later on about whether we should continue using the mask or not. What about the nature of the mask? There was this experiment, this study which was carried out in a small cohort of people looking at use of the mask and the respiratory droplets getting transmitted. And it was found that use of an N95 mask was more efficacious as compared to cotton masks that we have. I'll skip this and I'll come back to our topic and then we'll start the panel. So the beginning of the end or the end of the beginning, remember that in the last 6 months, we have found that SARS-CoV-2 has gradually moved towards endemicity. The US infections are, however, rising again as we speak in May 2022. The numbers that we have in the US are probably still an underestimate because a lot of it is home testing, the lateral flow testing, and these never get reported. The emergence of the subvariant Omicron and the more recently identified subvariant, which is BA.2.1, are causing increased transmissibility of infection. The BA.2 has effective reproduction numbers which are much greater as compared to the Omicron we had in India towards January to April 2022. The new mutant strain that I'm talking about has 2 additional spike mutations, which makes the disease more transmissible. The CDC, in its recommendations from 5 days ago, has said that masking is only required in areas where there is severe transmission or high rate of transmission of infection. A question that I often get asked, and we'll discuss in the panel again, is whether one-way masking is useful. So if all of us were in one room, I was the only concerned person and put on my N95, would that help when others are not wearing the mask? And the answer is, if you wear a well-fitted mask, it's likely to help. You can see the name of 2 masks on that slide, the N95 and the KN95. The KN95 is the Chinese authorities licensing the mask. The N95 is the American NIOH, National Institute of Occupational Health, licensing a mask. And it's thought that the N95 provides better protection as compared to the KN95. Are vaccine boosters important? The vaccine boosters are important. The government of India, as we speak, are under discussions about the 4th and 5th dose of the vaccine. Data from Israel shows that in the elderly population, in the population of people who have comorbidities, giving a 4th dose of vaccine seems to be relevant. The US has now started the process of the 4th dose of the vaccine, the 2nd booster to be given. I'll skip those and I'll come to this last slide, which says that it's clear to all of us now that SARS-CoV-2 will never be fully eradicated. This means that we will continue to adapt our life to COVID-19 going forward the way we have done in the last 2.5 years. The community transmission will continue to be high. When the community transmission comes down, protection can be dialed down, and then when there is a small spike, the way I showed you a little while ago, the mitigation efforts need to be dialed up again. The reason we are still so cautious, the reason we are doing meetings like this today with the Chest Council of India, is that 10 to 30% of people who are having infections even now seem to develop long COVID. And there is evidence to show that vaccination reduces the symptoms of long COVID. Hence, it makes sense to identify infection. It makes sense to use the mask in areas which are crowded, where there is potential of infecting people, in population of patients who've got comorbidities, and continue to vaccinate people according to national guidelines which are available throughout the world globally. So thank you for listening to me. We'll go straight to the panel. If I can have the live audio feed of all my colleagues, wonderful. So I can see Vijay, I can see Dr. Narayana, Pradeepa, I can see Nitin. If I could see Ravi, could we see you? Wonderful. So we'll start the panel with that perspective that we just had. And I'll go over to my good friend, Dr. Nitin Abhyankar. Nitin, I'll start off with a thoughtful question and pick your brains. So we have tried to lay a background. Tell me your thoughts about what you think is the future of the COVID pandemic in the coming months, depending on what you see, what you feel, and what your reading of the literature is. Over to you, Nitin.
Yeah, I think first, I'll start sharing the screen in any case, because I have a few slides to share. So
Sure.
I'll just make sure that that is happening. Are my slides visible?
Yeah.
Okay. So I think in simple words, I don't think, as Raja, you have very rightly pointed out, we started with H1N1 nearly 12 years ago, and we still are living with H1N1 cases. So I don't think this particular virus is just going to go away. So I don't think there is no real end of COVID-19 to be visible in this near future. So what are we expecting in the near future is dependent on what happens to the virus, first of all. And what is being described in a beautiful article by McKinsey, and I'll try and share their names, is if I get a milder cron, if I get a Omicron twin, or if I get a Delta cron. What it means is that if I have a milder and milder version, as it has been happening, that Omicron is a milder and milder version. So I seem to get more infectivity, but at the same time, the hospitalizations are relatively minimal as compared to the previous Delta pandemic that we had, or Delta surge that we had. And then the Omicron's twin, where you would see similar number of hospitalizations. So it is like it's not getting better, but at the same time, it is not getting worse. But if I have a combination of a Delta and the Omicron, that means more infectivity and more virulence. And this is what it's completely unpredictable what will happen in the coming months, how the virus tries to adopt. So whether it is milder cron, whether it is Omicron twin, or whether it is Delta cron, this is going to be the decider. And we really don't have any control over this. This is the natural history of the virus. I'll move on. So this is what, and in the next 3 slides, I'll try and show you what happens in US at this point in time. There is a big surge, and in fact, it is going on. But even in the US, what they're expecting is 2023 will not be as bad. This is what the article says. But at the same time, we have to understand that, look at Omicron. Omicron was essentially a relatively less lethal disease and more transmissible. So this is something which will probably infect more than 10 people. The Delta was infecting maybe 6 to 7 people. Polio or the other ones, or for that matter, even the Alpha was less infective comparatively. So the infectivity has gone up, except for Delta. There has been no increase in the virulence. So I think if we expect this to continue in the same thing, but if you really, even with that kind of an argument, this is what CDC has put up, and this is their national forecast, which is combined forecast. What they are talking of is in the month of June to say June 25, they are expecting something like 1,800 to 5,400 deaths weekly in US. This is the US data. We are not really talking of the Indian data. But if you really look at what is likely to happen based on what is happening at this point in time, this is a CDC recommendation vis-a-vis the recommendation, or this is the prediction by the McKinsey article, and I'll come to that finally. So if you really ask me, I don't think we are as bad as the CDC forecast here looks like. I don't think we are seeing those kind of deaths at all. I think as a country, we are moving towards this disease becoming endemic. And if it is becoming endemic, then the level of depending is divided into 3 components. One is individual endemicity, that the person who starts feeling no more, I'm going to have my holidays, I'm going to have my gatherings, I'm going to travel, all that. That is the definition of the person has accepted that individual is no more susceptible, and he is ready to take the risk. There is an epidemiological endemicity where the countries and the society defining interventions go away. And the last, of course, is the economic endemicity. And I think we will not really go into the economic endemicity, but what it means is that it takes the longest period of time to come back to normal. So I think when we are thinking about the end story, we have to look at eventually reaching the economic endemicity. I think most of the India has already reached individual endemicity. So I think in a nutshell, that's what I think. And that's what I feel, that we are past the worst. And I think I'll stop sharing and we go back to you all. Thank you.
That was lovely. Very nicely put perspective. Thanks, Nitin. Let me explore this question a little further, and let me come to you, Narayana. So, Dr. Narayana, Pradeep, you know, you still have reports from Dr. Abhyankar state, from Maharashtra, that there's a small spike in the number of cases. In Bengal today, we seem to have relatively very, very few cases, even though there's been alarm a few times. I'm sure it's different in different parts of the country. So even within a country where there's so much of traveling, people have thrown caution to the winds. If you look at the airports, they're so crowded, you cannot walk to save your life. Why do you think there is so much of variability within the individual country? And then I'll talk about the globe as a whole in a minute. Narayan.
Yeah, yes, sir. There is a lot of variants are there definitely. In the even if we see between the two districts, also we can see the differences for the among the severity, number of the spikes, then number of behavioral as such. Even not only country, even in one state and within the district, within the one particular pockets are also different. That is the how it is mysterious virus even today.
Sure. Sure. So important point that you make, Narayan, the fact that there are a lot of mutant strains even within one country, and India is a very large country with a very diverse population. There's also, I guess, the question of which part of the country gets more infected, where there's crowding, the amount of traveling that a particular state does vis-a-vis another state. And there's also the question of vaccination, etc. So let me get that question to Vijay. Vijay, coming to you, there's variability in the country, but then throughout the globe, you heard what Nitin said a little while ago about the cases going up in the US. It's the same in Germany. The number of cases in Spain, in countries like India, seems to be very, very low. So what do you think? So two parts of the question, and then I'll go to Ravi. Two parts of the question. The first is, what do you reckon is the reason why there is so much of diversity throughout the globe? And second, how do you think things will pan out? So we also heard Nitin and I spoke about the fact that we seem to have reached an endemic state. So even within this endemicity, there are people who are predicting lots of deaths, thousands of deaths in an individual country, whereas we feel that the disease is tapering towards an end and dying out with endemic disease, which is going to be asymptomatic or mild. So tell me your thoughts about the variability, tell the audience thoughts about the variability and why that is, and how you think this will unfold over the next few months.
Rajabhai, first of all, okay, a huge congratulations to both of you for wonderful talk. So with that, the first important thing is diversity. If you look at global vaccination, we feel that Indian government has did wonderful job in vaccinating, but having seen the exact percentage of vaccinated individuals across India, if you look, it is approximately 65%. And from in states where I happen to visit, Shillong, Meghalaya, so their government has taken such a keen measures that they went for tracing one family. They may need to go walking in the forest for almost 6 kilometers, 7 kilometers, 8 kilometers as well. Even there, in such a tough scenarios, they've done a pretty good job. They have vaccinated. Few states have got vaccinated extremely well. So like that, there are globally, if you see, China has got 89% of vaccination as per the data that they have provided in the adults. Russia, 51%. But the efficacy of vaccine also very, very important. So if the vaccine efficacy is low, probably they may have good number of cases. So that's one thing which I want to state. So the second important thing is, and the endemicity within the pockets, there may be many variants, sub-variants available, which we may not be know. We have not typified them. We don't know. So because we Indians work with a lot of limited resources. So unless there is a crops of new pneumonias, new sick cases, it is very difficult for us to genetically identify which variant that this number of cases belongs to. That's an important thing which we must think of. So, but to the forum, my prediction is COVID has not gone. Okay, there is every chance that it can bounce back. There's a chance that, new variant is going to come up. So as Nitin Bhai was mentioning, Delta Cron, if at all, if it occurs, it may have more virulence, if at all, if the Delta component expresses more. So let's be more vigilant and then take decisions as per the current status. That's what is my take.
Sure. Thanks, Vijay. So important points that you've made, I think. So you spoke about the vaccination, the variability of vaccination across various states and across the globe. You made a very important point, which is about the efficacy of the vaccine and the fact, and I'll come to Ravi with this. I wasn't intending to ask this question, but I'll come to Ravi with this. As the virus mutates, the efficacy of vaccines also become lesser. So with Omicron, we know there's good studies to show that the mRNA vaccine seems to provide lesser efficacy unless you give people a booster, which is why the booster came in the first place. So Ravi, two questions for you. First is your thoughts again about this variability about the disease process. We have spoken about the human host. We have spoken about clustering. We have spoken about vaccination. Any other thoughts? That was one. And the second question I wanted to ask was, the human race, when we have seen viral epidemics, we've not really seen a pandemic in the last 100 years till the influenza pandemic of 1918. But in the last 100 odd years, when we have seen epidemics, we have seen that the virus gradually becomes weaker over a period of time and becomes more transmissible. So more transmissible, weaker. However, like Nitin described a little while ago, with this particular virus, we seem to have gone up on virulence when we had Delta. So the Delta was definitely more virulent as compared to what Alpha and Beta was. Now we are coming down. So your prediction as to what's going to happen in the future when the virus mutate again from Omicron to other viruses, are there chances that we might have a more virulent strain? Or do you think that the virus is going to become an endemic disease, like we've all said, and very low in virulence, and we'll only have asymptomatic and mild disease in the community?
Well, good evening to all of you. And thanks to CCI to make me a part of this discussion, a very relevant discussion, a brilliant discussion by Raja sir and Nitin sir. Actually, I would like to equate the situation of COVID with the 5 principles of the DOT strategy. They say that it is based on political will, rapid diagnosis, adequate drug supply, directly observed treatment, and accountability. I feel it is varying features of all of this throughout the world, throughout our country, at times even in the state, which leads to a lot of variation in how the disease comes and how it is managed. As far as the disease is concerned, this virus is definitely behaving in a way which is very much different from the previous pandemics. That is why it is becoming more of a problem rather than less of a problem now, because on one hand you have more infectivity, on one hand you have higher virulence, which is very abnormal down the pandemic. That is why what I am starting to consider is, sir, that with every mutation, it is like a beginning of a new epidemic. It is not the same pandemic which is continuing. It is multiple epidemics happening one after the other. That is why the basic precautions which we have to use of social distancing, masking oneself, and proper and logical sanitization along with vaccination will stand their place in the that we face. I think that though vaccines, like you very correctly told, I think vaccination is the only way forward, and that is only how we'll be able to rapidly take care of these multiple epidemics which are happening.
Sure. Thanks, Ravi. We actually lost you for I lost you for a few seconds in the middle. But from what I gather, I really liked your analogy with the DOTS program. I think that was brilliant. Do you want to spend a minute just elaborating on how you think these 5 principles actually match up with the COVID-19? Because I think that's an important message from the audience. So can you just elaborate on why you think they are sort of similar?
Sir, political will I
Sure.
think it's everything. It's everything,
Sure.
because if we have a strong, like CVK sir told, that in Shillong, for tracing one family, the administration went through forests. That sort of political will and commitment.
Sure.
We
So
need
political
very
will.
important,
Second,
very important. Second, rapid diagnosis, the availability of not only RT-PCR but even genome sequencing,
sure.
which is being made available and being done at random now, is very important in early identification of mutations. Before the thing actually becomes a major thing, we at least know what is in offering. Means even one case you get in Calcutta, in Kolkata or in Pune, and a person sitting in Indore knows ki haan, ye strain has now entered India,
Sure.
so beware. So
Sure.
that is one very important thing, sir. Then the third is drug supply, adequate drug supply. We have good stocks of remdesivir and even the other cytokines from controlling medication now. The paucity and oxygen supply is very much adequate. That is very important for rapid control in case of epidemic breakout. Then the directly observed treatment, though not applicable directly in COVID, but see, if what I can take the analogy is, if we administer the dose early, that means catching the disease early and administrating the proper treatment early in a protocolized way. That is what has happened, at least in India. We have proper protocol for pediatrics and adults in place by the Ministry of Health and Family Welfare. So I think that is one thing which is very helpful for us. And accountability, we are having to give regular feedback. So I feel these 5 principles, we are working on the same line, and that is why India, I feel, is in a relatively better position as compared to other places.
Wonderful, Ravi. So with your permission, I've learned something and I will use this in my future talks when I talk about COVID. I think that's brilliant. I think Vijay wants to have a quick word and then I'll go to Nitin. Vijay.
Absolutely brilliant analogy. That's what is my comments. That's
right. Grand. So let me come to you, Nitin. Nitin, what Ravi has said actually has opened a few questions which I was not going to ask. I'm going to ask now. So let me come to viral stockpiling, right? So we've seen that in influenza. You have said and I have said that the disease has become endemic and it's become mild. Stockpiling uses up a lot of economic reserves of a country. So do you think drugs like the ones Ravi spoke about just now, the remdesivir, the favipiravir, the molnupiravir, all the antibodies, the antibody cocktails that we've become so familiar with, do you think as a country we should stock things up? Do you think that's something which is required? Do you think it's required only to a small extent, a large extent like China is doing just now? Or do we just say it's going to be mild disease, leave it, let it go? What do you think?
I have a feeling that, we should focus on stockpiling things which will prevent transmission, because I think the future strains will be more infective. They may or may not be more virulent, but they will be more infective. So I think things like molnupiravir have a better priority in my mind. That is one thing. I don't think we have to stockpile something like amphotericin B, which we were running short in the second wave. It is crazy, but I think some amount of stockpiling of a molecule like remdesivir may be relevant, but it should be used. I think I always keep on harping on this issue that if I have to use an antiviral, I have to use it in the first 24 to 72 hours, not after day 6 or day 7. So I think that is one very important prioritization, that if I am using antivirals, I have to use them early on rather than late. So that is the second part of it. And that kind of a strategy is possible in a country like India. So it's not all that impossible. UK has done that in H1N1 remarkably well. I'm sure we can do that. So I think stockpiling, not just stopping at stockpiling, but distribution at the doorstep. And UK was doing that in the H1N1 epidemic or pandemic, that they were delivering, just if you give correct information on phone, they were delivering the tablets of Fluvir at the doorstep. Of course, whatever that brand name there was, but they were given at the doorstep of the patient who is symptomatic and is in the middle of a pandemic beginning. So I think if there is no other option, that could be the better way. So it's not only stockpiling, but a methodology of distribution. That also may make better sense. Beyond that, I will still harp on the idea of, yes, I think this is milder and milder and milder, rather
Sure.
than and hoping that it
Sure.
is not going to get severity
Sure.
wise. I hope that in that slide I showed Deltacron on one end and the Omicron minus or whatever that was. I would hope for Omicron minus or whatever,
Sure.
milder one. So I think
Sure.
Cron mild or whatever. Yeah.
Sure. So again, very important comments. A couple of things that I want sort of the audience to catch on to what Dr. Abhyankar said. So he said about stockpiling, but stockpiling of preventive measures more than stockpiling of drugs. And I think that's very relevant. When COVID started, people on this platform and a lot of people outside listening to us just now were caught unawares, and we did not have personal protective equipment. The masks were less functional, they were less in number, and the stockpiling of personal protective equipment is something that we need to be far more vigilant about now, because even if it's not Omicron, even if it's not SARS-CoV-2, we will continue to have other epidemics, respiratory viral pandemics, which will come in the future. And these personal protective equipment, the N95, the KN95 masks that we spoke about, will still remain very, very relevant. About drugs, I think we need to be vigilant, like both Ravi and Nitin have said. I think we need to be cautious. We need to have a certain supply. But I agree with Nitin in that we don't need to go overboard by stocking up to an extent that our resources run out, because we are stocking drugs for very severe COVID and severe COVID, which might not be very useful in large numbers going forward in the future. So that's about stockpiling. Let me quickly come to, I was going to come to Dr. Narayana Pradeep. Yeah. So Narayan, can you hear me?
Yes.
Yeah, is your connectivity okay?
Can I add one important point, Rajabhai?
Sure, Vijay. Sure, go on.
Here, if you look, the question also contains whether we need to stockpile monoclonal antibodies. So
Yeah.
definitely not. So because it is changing its structure with every variant. So
Sure.
the monoclonal antibodies which were be useful for the previous wave
Yeah.
may not be efficient in the current wave or forthcoming wave. There is no point in stockpiling the monoclonal antibodies.
Sure.
Thank you.
Sure. So very important point which Vijay makes, and I want the audience to hold on to this thought. Most of the drugs that we have actually work on the spike protein region. You remember from my talk that most of the mutations that happen are in the spike protein region. And while the monoclonal antibodies will become non-functional the way Vijay describes, even like drugs like molnupiravir, etc., which work through the spike protein region, probably are going to have less efficacy going forward with the new mutant strains that we have. So that's something that we need to keep in mind, whether we are stocking with antivirals, whether we are doing monoclonal antibodies, etc. So question on similar lines for you, Dr. Narayan Pradeep. So Narayan, what do you think is the future of, let's start off with masks. I was going to ask you SMS, but let me start off with masks. The entire country has gone crazy. I was in North Bengal a few days ago, and I had to look around in the airport to find a single person wearing a mask in Kolkata airport, or even in North Bengal, Bagdogra, where I was at. The people don't even remember masks, it seems, anymore. We had a singer pass away after a concert in Kolkata very tragically 2 days ago. Not 2 days ago, but yesterday. And you wouldn't believe it. Our auditorium, which was designed to have 2,500 people, had 7,000 people in it. 7,000 people in a hall which is equipped to handle 2,500 people. So we have no caution measures. Let me ask you, in an ideal world, what would you do about masking? What are your thoughts? And how do you think we'll move forward? Let's not say to this audience that you need to mask all the time, because no one is going to listen to us. So let's give a practical answer which can be followed by people. So tell me the population where you would want masking and the circumstances in which you would want masking. Narayan, all yours.
Thank you, sir. As Ravi mentioned, we have to learn from tuberculosis again in this case also. So masking also, as we work, when we work in the TB ward or MDR ward, how we take precautions. Same things we have to think in that line, how we educate our TB patients. So how that lines we have to educate our public as well. So
Sure.
masking, we have to tell that when they are symptomatic, they have to use it, because that is the only thing.
Sure.
They have to remember that to prevent the disease to progression
Sure.
to their near ones, to loved ones, they have to take first precaution. Number two, we have to tell the elderly population and vulnerable population, patients on dialysis, patients who are diabetic. So diabetic is increasing now. In Kerala, we have got epidemiological survey stating that almost 42% of the population is diabetic, adult population. That is a huge number.
Sure.
And people on CKD dialysis also number is increasing nowadays, and that people then patients on immunotherapy or other immunosuppressive diseases, they have to be at risk and they have to be cautious. Then public gatherings, you have to avoid. The symptomatic person has to avoid that. That thing should be still in his mind. So whatever said and done, it is like we can't ensure it, but we can at least tell that if you are symptomatic, just sit in your home. No need to go to the public function.
Sure.
Function will go on even without you. That things we have to be much more practical things which we can communicate.
So wonderful messages, Narayan. So one is you've said symptomatic people, which I think is very relevant. So any symptom, even mild symptoms, is something that you need to be cognizant about. So that's one. And then you spoke about gatherings, crowded places. Those are places where the distance of 2 meters or 6 feet that I spoke about can never be adhered to. The example I gave was a classic one from Kolkata about the concert a little while ago. So that's number two. Any other, I think this is an important question. So we'll dwell on it for a couple of minutes more. Vijay, let me come to you. Your thoughts, masking, any other groups, what's the way forward?
See, first of all, I always gives my patient a good analogy. When there is a part which they want to take water, they carry to a different place. When it is leaking, it is important to identify the leak and then stop it rather than pouring the water time and again. So similarly, as I completely agree with Narayan. So what important message here is they must wear as soon as they have symptoms. It may be COVID, it may be non-COVID related upper respiratory tract infection. It is very, very important to follow this rule of masking, self-masking, that makes the individual more responsible. First important. Second important thing is we must carry some information from this countries like Japan, like that. So the moment they become symptom, that may be simple allergic running nose, allergic rhinitis, they will wear a mask.
Sure.
That is the response. They are behaving as a true citizens of their nation and then globe. So they be more responsible. That is what is very, very important. And if they don't leak the virus further, we can contain. And second important, for people like us who are really, at high risk, this is very, very important to be role models to others. So whenever we are attending gatherings, yes, now we are attending, malls, movie theaters, and then a lot of functions we are attending. So when we are attending, we should set us as a role model to others. Wear a N95, okay, because it's a huge crowd that is coming. So as you rightly said, Rajabhai, in your talk, if you still wear an N95 mask, which is compactly, placed, then absolutely, I'm sure, because we have treated thousands of patients, we could not get the virus transmitted to us. So the reason being, we are protected. When the seal is perfect, you are protected, and be a role model.
Wonderful. Thank you. Very important points. Just one point I will add to this and then move on and go on to sort of Ravi is try and make sure that your vulnerable population, the high risk group, is protected. So that might be your parents, that might be your elder ones, your grandparents at home. And if healthcare workers like us who have good immunity carry the infection home as asymptomatic carriers, you actually put your vulnerable population at risk. So I think healthcare workers, like Vijay said, is very, very important. Important not just for yourself, but important for the high risk population that are going to. And make sure if people with comorbidities, people who are elderly, are going into crowded places, make doubly sure that these people mask up. So that's one population which the CDC points out, which the ICMR points out, who should still remain masked. Masking is going to save lives. It is the single most or one of the two most important interventions that we know of in COVID, which works and works for sure much more than all the drugs put together. So let me come to Ravi next. Ravi, another important question, and this is $1 million question, and probably I'll get this question to someone else too. What about testing and isolation? So I know Vijay spoke a little while ago about genome sequencing. That, of course, will get done in a small population of patients with the intention of knowing the variants and the mutants. Nitin also pointed that out. But generally, we're talking about the RT-PCR test. We are talking about the rapid antigen test. We're talking about lateral flow, the self-testing. How would you test? Who would you test? And now you've tested. You've got someone who's asymptomatic or mildly symptomatic. How would you isolate? How long would you isolate?
Sir, testing is paramount to controlling the epidemic, because the earlier you diagnose, the easier it becomes to treat that patient. If a patient is mildly symptomatic, then rapid antigen testing is not something we advise. They will usually come with the test already done at home. But if I want to confirm it, I would like to definitely go in for an RT-PCR. I feel RT-PCR should be done at a very subsidized rate, at a very high numbers, because the more you diagnose in the community, the easier it is to control the problem also. As far as other testing is concerned, like genome sequencing, that is definitely limited to epidemiological survey to a sample population only. But RT-PCR, I feel, has to be done, particularly now is a scenario when a lot of people are coming back from mountain, means for summer vacations, they're going to mountain places, to hill stations, and they are coming back. And a lot of them are getting cough and cold. So I think they should definitely get themselves tested. Let it be rapid antigen at home. But if they are persistently symptomatic, they should be advised in RT-PCR and they should be diagnosed early. Then as far as the isolation period is concerned, sir, I feel 7 days from your initial symptoms is something which is recommended and should be done. And I would recommend that wearing masks inside the home when you're isolating yourself from the society is equally important. Means you should mask yourself outside and inside if you're symptomatic for those 7 days.
Sure. So Ravi, I'll quiz you a little bit more on this and then go to Nitin with the same question. So let me give you a couple of hypothetical cases. So you've got someone who works in the IT industry, lives at home with his wife, who gets a bit of runny nose, right? So wife is asymptomatic. The guy decides to go to work, but go to work with a mask on. He asks you, is he doing the right thing? Would you insist that he needs an RT-PCR, as does the wife? Would you advise him isolation for a period of 7 days, like you said? Or would you say that you're going to the IT industry, more than likely with people with normal or good immunity, make sure you wear your mask all the time, make sure you monitor for symptoms, maybe take an anti-allergic to reduce your symptoms, but you don't need to test? Which way do you think the world will go? What should we do?
Sir, if that particular individual is a young person with no comorbidities, I would allow him the liberty to work with a mask on with anti-allergics. But suppose he is somebody with comorbidities or a previous history of COVID infection or any other respiratory infection, I would advise him to go in for a COVID RT-PCR, because he has a wife at home and he is going to work. He might be a potential index case in that particular environment. So it depends on his comorbidity and immune status. Suppose if he is a smoker or an alcoholic, I would definitely advise him to get himself tested to avoid any complications which are avoidable. And I would advise him that since you have chose the IT sector, I would ask him to do work from home if permissible in this particular situation.
Sure. I love that answer. So I love the answer because of two reasons. I think we are implying today, or we are explicitly saying, not implying, that this is endemic disease. And going forward, it's going to be everywhere. So if you have a common cold, we don't ask people to sit at home and do nothing. We ask them to take medications. We ask them to stay away from people as far as possible. We have added in, because we have learned that masking is in a very effective way. So we're adding in the masking. So the message to all of you is not to go about testing for every little cold that you have. If you have comorbidities, if you're elderly, like Ravi said, or even more importantly, if you live with people who are elderly with comorbidities, make sure that you mask up and you test if you have comorbidities yourself. if you are at work, make sure, or if you are in school, for instance, make sure you wear the mask during the entire duration, because otherwise you will be unnecessarily putting other people at risk. So those are very, very important messages. Thank you, Ravi. I really liked your answer. I like your answer about 7 days of isolation. I think that's good enough. The UK has gone to 5 days, but I think that's over the top. And that's because their manpower numbers are minuscule. That's why it's 5 days rather than 7. I think the 7 is a fair number, and I would stick to that. Let me come to Nitin with a different question then. Nitin, the flights are all booked. I'm sure you've tried to travel and struggled to buy tickets in the interim. So what are your thoughts about intercity travel, inter-country and intercontinental travel going forward? Everything is opened up, so it doesn't really matter what we say on this platform today. But do you think we have been presumptuous? Do you think we have opened our floodgates a bit too early, with places like the US, places like Germany, some other places in Europe, East Europe, for instance, infection numbers going up and there being mutant strains like you've pointed out and others have pointed out? Do you think we have become presumptuous and we might have to close borders again? Or do you think we are doing fine with the way we're going?
I think we are doing very much fine with the way we are going. I think we have to unlock. I don't think a country like ours can sit into a lockdown forever. It is unrealistic. It's economically non-viable. So many issues will come in. And more importantly, if you really look at the kind of, the seropositivity that this country enjoys, I think most of us are protected from most of the known strains up to Omicron. So I think from that point of view, unlocking is the right way ahead. At the same time, I think this is a bigger worry for a country like US, where there are vaccine no sayers kind of thing. 30% population refusing to take vaccine. I think that is the problem area. If you really see, completely naive people who have never got exposed to this virus are the ones, and then they have comorbidities. They are at the highest risk of getting a fatal disease. I showed you that slide, 1,800 to 5,400 deaths projected per week. I don't think that has happened in this country for last 1 year after the second Delta wave. So I think Omicron, we did not have even 100 deaths in a day, 100 deaths in a week, in fact, for that matter. So I think it's a part and parcel of two-pronged things. One, we are a already overcrowded country, and therefore the transmission was very high with Omicron. And second, we have done a great job with vaccination. So I think we should continue on the path of unlocking and take advantage of the situation, and we remain and develop our position, strengthen our position in the economic sector also. So we already have entered the economic endemicity as I see it.
Sure. So very valid points, Nitin. I agree with you. With a word of caution, I think closed spaces like a flight are probably the most dangerous places you can be, even if you had one patient. And this is not me just saying it. There have been buses that have been sampled with one symptomatic patient, the entire bus getting infected.
Correct.
The flight probably would be even a more closed space. So I'm not suggesting you don't travel. I completely agree with Nitin. I think borders should be open. People should have travel. And
even the testing part, let me make small comment on that.
Sure.
The testing has to become strategic. So whatever testing we are doing, we should not be doing, because we are seeing that my wife works as a microbiologist, and say one person comes positive in a family and the entire family undergoes a testing. Why not assume that the entire family is positive and isolate yourself for 7 days? What's the big deal? I mean, if that can be done, of course. If 7 people who are working and earning bread in a family is unusual, so the remaining 6 can very well, jolly well stay at home. So I think the strategic testing, and therefore strategic testing of people who are likely to travel in closed spaces, is not a bad idea even today. It's worth it.
Sure. Fair point. So agreed, Nitin. So travel is a yes. Traveling cautiously is again a yes. So I think that's important. I won't ask about hand sanitization. I'll just make a comment and then move on. I think hand sanitization is one of the important things that we have learned, and we should carry this forward irrespective. I think it's important for all diseases. It's not just about COVID. And carrying your hand sanitizer with you when you're traveling, when you're entering a hospital, when you're entering a cinema hall, for instance, is good practice and should be one of the practices that we should persevere with, even post-COVID, even when it becomes a distant memory. I don't know whether it will ever become a distant memory, but if it does, then even then we should continue with hand sanitizing. Let me come to you, Narayana. So quick answers now. We have about 3 or 4 questions more, and then I'll start taking questions from the audience. So this is something I spoke about before. This is natural infection versus vaccination. So there's people like me who've not been as good as Vijay was pointing out. So I've had COVID twice, once hospitalized with it, and then I've had 3 doses of the vaccine. So I have the ceiling of immunity that you can hope to have, hopefully. And then there are people who have either had a vaccine or not been vaccinated and have had disease. What do you think gives you the best immunity between the two? Obviously, if you have both, that's the best immunity. But between the two, what do you reckon gives you the best immunity, and how long do you think it lasts? Narayana.
Yeah, so best immunity ultimately will be natural immunity, definitely, no doubt about it. And I think with vaccines, looks more than 6 months, it is good. Up to 6 months, 8 months. Probably we have to take boosters once in after 9 months or once in a year. That is what I feel. And regarding natural immunity, that also does not mean that patients should get a big disease and asymptomatic. It is even the small trigger can stimulate the immune system in the same way. The trigger remains the same. That is what my feeling is. It does not different people depending upon immunity, but that virus trigger that causes the your body to preparedness will be same, even it is mild or a moderate disease. This is what I feel.
Sure. Grand. So I like your answer very much. I think it's natural infection, more long-lasting immunity versus vaccination. That's what you said. And the fact that even antibody titers go up more when you get a moderate to severe disease. However, that is not what we wish to have immunity. Vaccination needs to happen. And let me come to Vijay then with my next question, which is as a natural sequence to this question. How often do you think we should be vaccinated, if at all? So let's presume everyone on this platform and even the audience today have had 3 doses. That's a given. That's a recommendation. All of us have had our booster, let's presume. Do you think we need a 4th dose? If so, when?
Continuation of what Dr. Narayan has mentioned. There are a couple of important papers which have been published. One almost a year old, and then other was till recently around in February. So a year-old paper from, I think, NEJM has said clearly that vaccination in addition to the natural infection would cause long-lost immunity. That's what is very, very important. In presence of vaccination, definitely in addition to vaccination plus the natural infection is causing long-lasting immunity. And second important thing is, in the Nature paper, which was published in February 2022, which clearly mentioned that a natural infection gives an immunity to entire virion, and it causes at least 27 times more for the cellular and then antibody-mediated immunity. That's what is the point which I want to make it. And coming to the next question, can you please repeat the question, because I lost you?
Or did you? I was actually going to ask that. Is my voice audible, or have I got a poor link? Because then I'll shift to a different link. Am I audible?
No, you are audible. Somewhere you are breaking. Yeah.
Okay. So what I was asking is vaccination, post 3rd dose for all of us.
Yeah.
What are your messages to the audience? Do you think it should happen at all? 4th dose, 5th dose? Or do you think we are done and dusted with COVID vaccination if you had 3 doses?
See, at this moment, if you have had natural immunity, this is completely not evidence-based. This is completely my opinion. So if you have had natural infection along with the current 3 doses of vaccination, I'm sure till the next regulations are available, unless you are a high-risk individual where your diabetes is uncontrolled, and then you are having other medical chronic problems like liver failure, renal disease, heart failure, or chronic pulmonary issues, or ILD, these kind of things, you don't need to vaccinate it till the government ICMR issues the new guidelines. Otherwise, if you are at risk, definitely please get it vaccinated at least probably annually once. That's what is my suggestion.
Sure. So from my understanding, Vijay, going along with what you said it's your personal thought. So my understanding from the government of India, the ICMR discussions till date, is that we're going to vaccinate for about 5 years, starting from the first dose. So that's going up to about 2026. That's probably how the proposal has been put forward to the government. It's still being looked at. But watch this space is what we say. And like you said, the fourth vaccine is probably definitely going to come as we go forward. Welcome, Krishna Bhai. Good to see you. Warm welcome.
I can tell you some inside information about the fourth dose from Covishield is nearly ready.
Okay.
Nearly ready. Yeah. So
Okay.
and it will cover the Omicron actually.
I just as they tell that
yes, sir.
Upakatha makes Harikatha more interesting. You know, when they tell Harikatha, there'll be Upakathas. And that will make the entire thing interesting. So I'll tell you, in South India, we are called by initials. For example, C. Vijay, Kumar, Chennamchetty, CVK. It's not like Nitin, Abhyankar in Maharashtra. It is like we have initials in South India. So this is a true story of a person who has initials in his Aadhaar card. But in his passport, the initial doesn't support. He has to take his entire name there, his surname, his father's name and his name. So in passport, he has got the entire descriptive name. In Aadhaar card, he has got that short name, initials with his name. So his surname is within one initial, his father's name is with one initial, then his name. So initially what happened, Covaxin arrived to the market. This person went and took Covaxin. Again, after 28 days, on the basis of Aadhaar card, he took second Covaxin dose. After few span, he understood that he has to go abroad and Covaxin is not accepted. Now he has to take Covishield. Now he cannot take Covishield on the basis of Aadhaar card. He took his passport number. On the basis of that, he took first dose of Covishield. Then he took the second dose of Covishield. Later, when he understood that now Covaxin is also accepted to travel. Now, when he understood that Covaxin is accepted to travel, he became very happy. He took the precaution dose of Covaxin again on the Aadhaar card basis. Then someone left an insect in his brains. What did you do, man? You are crazy. In the passport, your name is there in a well-descriptive manner. You should take a booster dose for that, not for the Covaxin. So he took the booster dose of Covishield also. So 6 vaccines in total. In the meanwhile, before Covaxin and Covishield came to the market, there were no vaccines for COVID. When the first wave was at full swing, then he was quite educated regarding an immune modulator, something like someone educated him regarding Mycobacterium welchi. He took 2 doses of that. So there is a person who has taken 8 doses of vaccine. The sorry part of the story is earlier Covaxin was not approved, then it became approved. He has to go to Covishield. So for a person who has taken 8 vaccines, is he vulnerable?
So I wouldn't know, Krishna Bhai. I think it's an interesting story, but I mean, not maybe 8 doses, but you know the entire Middle East. So the entire Middle East is vaccinated 4 times over. And there are people who have traveled from India to Middle East who have been vaccinated twice in India and 4 times in the Middle East. Have they got higher antibody titers? Does the higher antibody titer translate into better immunity? Which antibodies should we measure? I don't think we have answers to any of these questions, Krishna Bhai. I think we probably will have going forward.
You are not coming to that person's rescue, because no, he took Covaxin, then he understood it is not permitted to travel abroad. Then he took Covishield, then Covaxin became approved. His name is in different, presented different way. What else he supposed to do?
So Krishna Bhai, I think he should go home and introspect and say that I will never do this again. That is probably.
So in Aadhaar card, his name is NH Krishna. In passport, his name is Navale Hanumantrao Krishna.
Is it? All right. Okay. So you've had 8 vaccinations. I will say no more then. I will say no more. Especially on this platform.
Yeah. So I'll again come back at the end for the concluding remarks.
Yeah.
I just thought that
Sure.
I will give some.
That's a very good story. Wonderful.
Please go ahead.
So
Please go ahead.
let me sort of move forward. Yeah, thanks, Krishna bhai. So let me move ahead. I'll come to you, Ravi, and I want short answers now. It's a long question, but a short answer from you. You know, the mindset of people about our specialty has changed completely. So respiratory medicine has become a sought after specialty now. You know, if you think about the medical specialties, cardiology, gastro, endocrine, neuro, nothing has gone away, but respiratory medicine has moved right to the top. I know of postgraduate trainees who would now, or aspirant postgraduate trainees, who would now give their right arm and their left leg to get into a good institute in respiratory medicine. So I want a hopeful message from you, Ravi, about how you envisage the future of the coming generation, the would-be respiratory physicians, the would-be postgraduates, as to what the future holds for them in our specialty and how we would move forward in our specialty. Go on, Ravi.
Well, this COVID pandemic has brought a big highlight on the respiratory system and specialists which deal with this particular respiratory system, which are us pulmonologists. So I foresee that in near future, there will be multiple episodes of such pandemics and epidemics happening, and the search for chest physicians is going to increase only. Of late, people are going in for panel testing much more. We are getting much more positivity rate. We are isolating things like Boca virus and influenza A and H1N1 all the time now. So, and I am not an ID specialist, I'm a pulmonologist. So the spectrum of my work is also increasing. So what I see is pulmonology is now growing in its own potential. If we leave about our traditional tuberculosis and bacterial pneumonia practice, viral pneumonia is making our work even double or 3 times or 4 times also. So I see a very, very bright future ahead. Already respiratory was something which was good in terms of numbers, but now it is very high in terms of recognition also. So I foresee a lot of positive trend as far as pulmonology is concerned. I see a lot of technology coming in, and I see a lot of public attention and recognition coming in, which is something very, very much desired by newcomers, I think.
Wonderful messages, Ravi. So taking forward, I know there's a lot of youngsters, young pulmonologists, wannabe pulmonologists in this audience today. The future is very bright for all of you. You know, this specialty will grow for the next 10 years for sure, and then maybe plateau off. But now is the time to enter respiratory medicine, go forward into respiratory medicine, develop your subspecialty interest in respiratory medicine. The sky is the limit for all of you, be it interventions, be it treating airways disease, infectious disease, pleural diseases. There is no limit. The sky is the limit for all of you. So let me come to my last question, and I'll take this question across to Vijay first, and then maybe pick your brains. I have all of 2 minutes to complete this question though, guys. So Vijay, how do you think the practice of medicine has changed in the post-COVID period for all of us? And what are the positive learnings that we should take forward? You know, the learnings that should hold us in good stead even when there is no COVID or endemic COVID. What are the messages? What are the positives that we take forward with us?
Yeah, Ravi bhai, okay. Let me just recollect how my dean, when I was in medical school, okay, he is a non-interventional cardiologist, absolutely, but he was a more a humanitarian, and then he practices very good non-interventional cardiology. The first thing what he does in rounds, morning rounds, when his name is Subramanian, Dr. Subramanian, once he reaches a sick patient, he just tap his, okay, he's boosts his morale of the patient, and then tap his shoulder and then move forward. But unfortunately, in the first wave and second wave, we could not do that because he was my mentor. I was always doing, whenever someone is really sick, So I used to say them, okay, don't worry, we are there, we'll take care. All your problems will get sorted out. We need to, do these tests, and then root cause evaluation. Once we identify, then we can treat your problem in few days. That's how my counseling used to. But unfortunately, during COVID first wave and second wave, so we have kept we have practiced telemedicine intensely. So thanks to telemedicine guidelines across India, okay, every one of us have practiced very widely. And second, we have placed our patients far off, probably 2 meters away, and then take the history and then give the prescription. But again, I feel we are back to again pre-COVID era. So humanitarian approach always prevails, I believe, Dr. Raja.
Thank you very much. Thank you, Vijay. Nitin, anything to add as far as positive messages going forward compared to what Vijay said? So I'm also talking about digitization, which has been alluded to, digitization of medicine, doing meetings like the one we are doing just now for academics, So things like that. A few more points maybe to add on to what Vijay very, very brilliantly put forward.
I think one thing I may be old school. I think I have lost more hair than Vijay, but I was never ever in favor of doing telemedicine. In fact, I started and I stopped within the first 7 days because I was doing some horrible mistakes. I was never told to not see the patient. So I have always seen the patient. I have fought it right in the middle there. And that was my way of doing it. I may be right or wrong. I don't know. The future will tell us that. That's one. But the second more important part of it is, yes, pulmonologists have been given a great deal of power. But as the great Spider-Man says, along with great power comes greater responsibility. And we pulmonologists should not get into the zone of being scope monkeys, as Dr. Atul Mehta keeps saying. So I think that is also the, sort of a sobering message that the most important part, I think the last part, which I will say, is that I got involved into administration and team building in the beginning of COVID itself. And that team building was greatly important. Right from Ayabais to Mehtas to, the ward boys, I had to do a pep talk to everybody and I had to stand up with everybody. All the staffs were assured that, look, anything goes wrong with you, I am there to look after you. And that is something which I'm sure all of you have done. Ravi has done, everybody has done that. But I think that is something which we should not forget, because I think that team building creates the power which pulmonologists are enjoying today. And I think we should keep on doing that as much as we can. And as Vijay very rightly pointed out, that pat on the shoulder takes the patient into a totally different zone of confidence, and it is worth remembering all the time. Surely.
Sure, Nitin. So I completely agree. I think the human touch has a lot of healing power. And I completely agree with Vijay. I completely agree with you, Nitin. But I think equally, I think digitization of medicine, teleconsultations have a niche, small space. I agree with you. You should not prescribe without seeing a patient. But ours is a country where people want to seek second opinions. And we as a group, if we manage to refer our patients to our colleagues, even if they are distantly away, and you are a part of that conversation, the stethoscope is replaced by one of your esteemed colleagues, and you can discuss with in the presence of the patient, you can discuss with your colleague, doctor, and even the medico-legal implications go out of the window. And I think we should create platforms like that, where esteemed people, subspecialty specialists should be able to sit on a virtual platform and see patients who are difficult from tier 2, tier 3 towns, where people cannot access. The other thing I think we have learned is proper sanitization of our instruments, our spirometers, the mouthpieces, the bronchoscopes, etc. I'm learning that we should take forward that even when there's no COVID, the cleaning of equipment should be as rigorous as it was during COVID times. So brilliant points, all of you. Let me come to a couple of questions. I have kept Narayana out of the discussion for a little while. So let me come to Narayana first. Narayana, there's a question here which says, it's from Shirish Ratna Parkhi, Dr. Shirish Ratna Parkhi, who says, simple question, should doctors wear a mask in their clinic anymore?
Yes.
So simple answer. Was that Narayan, you or was it Nitin hissing out the yes?
Yes. You just have to show it to your patients that it is important. If you
Sure.
don't wear it, I mean, they are not going to do it. I
Sure.
think the message is, I'm sorry, Narayan, I'm taking this, but this is very important point. Masking the source reduces the risk of transmission by 70%. And the source is, if it is not masked, then even if you wear the mask, it is not important. And source will only mask himself only when he sees you masked. So I think you have to do that. There is no other way. Absolutely.
Narayan,
Exactly,
your
sir.
thoughts?
Yeah, because we see not only COVID, but TB also equally important because especially those we work in government sectors, we see a lot of TB patients as well. So it's compulsory even before COVID also. Now also it is compulsory. We will ask them to put the mask, and we also, when we have to tell that you have to wear the mask, we should be wearing the mask.
Strong
we should
message.
wear
I
the
am
mask.
glad you said that. Glad you said that. Agreed completely. There's a few questions. I'll quickly answer this. There's 3 questions and I'll club them together and answer quickly. So the first question is, let me mention the names, that makes it more relevant. So there's Dr. Murugan, who says that the virus is immune evasive, and if the vaccine remains the same, is there any point of taking a vaccine which was originally prepared against the original variant? That's question number 1. Then my good friend, senior colleague, someone I love, Dr. Pradeepa Banerjee from Mumbai, he's got lots of questions. I'll just say the one which is in line with what has just been said. He says, in individuals who've taken the 3 doses of the vaccine, because of immune escape, does it actually make sense to go on and have the 4th one? And there's another question which is from similar lines. So my thoughts, and you guys please chip in if you think any different. There are 2 points to this. The first point is that the vaccines that we have today, they are not unresponsive. It's not as if you get the vaccine that we have today, you will not develop antibodies at all. The antibodies that you get, the amount of protection that you get would be a finitely smaller between, say, the Covishield that we have just spoken about versus Delta, as against giving it to someone who is you're trying to protect against Omicron. So slightly reduced immunity in case of Omicron. The second point, which was made by another question down below, is the vaccine going to change like it does in influenza? And it will do. So the 4th strain, the one which Nitin was giving us inside information about, will actually be covering strains better, which are coming forth, the Omicron, the new 1.2.1 strain of B that I spoke about a little while ago. It's going to cover those strains going forward. So going forward, if we do vaccinate for 5 years, it is going to be a vaccine with changes rather than being the same vaccine over and over again. There's another question which I will take to Ravi. So there was this question about influenza strain being different for vaccination every year, came from Dr. Brajendra Srivastav from UP. There's a question about, let me take this to Ravi. Ravi, increasing cases in Telangana, increasing cases in Mumbai, Delhi. Do you think, Ravi, that the 4th wave is there?
Well, sir, I'll just like to answer this in another way. I never thought that the first wave actually ended up till now, to call that the 4th wave is there. It will keep on coming. It will keep on coming. God knows what is happening, what is not happening. Any and every prediction of COVID has proven wrong up till now. I think it's the basic things that we have to keep doing correctly. That is the only way that we ourselves and our society will be safe from COVID. So I think this discussion of waves is a bit, it is not a situation where you can be on guard and off guard. You have to be sort of on guard all the time as a physician, keep on suspecting COVID all the time. And for the general public, I think you need to understand that masking and social distancing are very much required, not only now, but maybe for 4 or 5 years to come still.
Ravi Bhai.
Wonderful. So,
Ravi Bhai,
yeah.
one quick comment. I think Ravi Bhai has read even NMC guidelines where they said, it's on a lighter vein, okay, doctors are not permitted to take alcohol beverages, okay, even on the duty, even without on the duty, okay. So We should be on guard always. Right. Thank you.
So, Vijay, you've implied that you're going to follow that guideline forever. Remember this. I'll hold you to it.
Vijay, I'm likely to retire early then. In that case.
We're on the same boat.
So one line answer, Nitin, from you, and we'll sort of finish off now, I think, with sort of closing messages. Again, my good friend Pradeepa asks, I have taken 3 doses of the vaccine. So Pradeepa is a young man, but above 60, I think. So 3 doses of the vaccine. If I become COVID positive with mild symptoms, how long do I need to isolate, and what is the degree of isolation? So short answer, please.
5 days is good enough for a doctor. For general population, it is 7 days. And you know your symptoms and everything else is good. I don't think more than 5 days is required for a doctor. I had Omicron recently, and I was out 5 days. 6th day I was on the job. Okay.
So I'll tell you what I did, Nitin. So I had Omicron in January, and I have not said this on a public platform before. So there were plenty of cases at the time, lots of admissions of people with comorbidities. So I actually wore a mask and worked only on the COVID wards during that time and stayed in isolation.
Yeah.
So I did not isolate. I just worked on. So there are various ways of looking at it. But I think great thoughts. Let me have some sort of parting thoughts from everyone. So I'll start off with Dr. Narayana Pradeep. Narayana, I can't see you. I'm sure you're there. Can I have your thoughts about one carry-home message that you want to give people? Remember, it's the 4th wave, which might or might not be there, like Ravi said. One message for the audience to go forward during the COVID times, in the endemic COVID times.
We have to start living with COVID. You have to learn how to live with COVID. That's all.
Okay. So living with COVID is the way forward. Narayan says, let me come to Vijay next. Vijay, your message to the audience.
Humans' memory is very, very, very short. They forget everything. They forget they are living like, okay, there was no COVID at all. But my dear friends, please be aware, COVID appropriate behavior, sanitization, masking, and social distancing is the rule of new post-COVID era. You have to stick to it. There is no other way that you can protect yourself. God helps only themselves who follow this COVID appropriate behavior appropriately.
Wonderful. Thank you, Vijay. Very, very social, very nice message. Proud of you. Let me come to Ravi. Ravi, your message.
Cough etiquette has been taught to all of us in our moral science chapters and when we were in nursery and class 1. We need to remember cough etiquette is something which we have to by heart. It is not something which we have to show in parties and everywhere. It is something which, if we as a society take up, we teach our children that cough etiquette is very important. We understand and practice it ourselves. Then let thousands of viruses come. Our society can never be penetrated by anything.
Sure. Wonderful. Thank you. So come to Nitin. Nitin, your message.
Yeah, I think we have to remember from this pandemic, the Delta part of it as the most important lesson giver. And I have stood for my father-in-law in an ambulance queue for his cremation for 4 ambulances. And I don't think we want to go there ever again. And therefore, our preparedness in dealing with viral infections has to change the perception, right from the word go that if I get a viral, it is not a minor infection anymore and I have to mask myself. So I think that message has to really, really go to the entire nation as a whole, rather than sort of, just few people wearing a mask and, urging others to keep doing that. So I think that message that the source need to be get masked, need to get as a mission to the entire nation. Not just doctors, not just policymakers, not just say. I think that is the biggest change that we can bring. And if we do that, so mask the source, then we have started the real act of actually preventing transmissions.
Wonderful. Thanks, Nitin. Very, very important message. Masking. Make sure you remember SMS forever. So one quick message from my side. I think people on this platform, people who are in the audience today listening to all of us, doctors throughout the country. I'm very, very proud of the way healthcare workers, especially pulmonologists, have actually fared in this war. We have lost a number of colleagues. And I think one thing that I have learned and all of us should learn is that unless you look after yourself, take the precautions. It's not as if you back out of the war. This war is ours to own. We need to fight this war, but we need to fight this war in a way that we survive to see it till the end. And all of you out there, please make sure as healthcare workers, as doctors, as pulmonologists, you take adequate precaution and look after yourself and your own family so that you can go forward and fight on in the future epidemics and pandemics that come to us. That's something that I want all of you to remember. I had great fun with this discussion. I learned a lot, really had fun. So thank you very much to CCI, and who better to hand over but to Dr. Krishna for his message to the audience on today's topic and then the concluding remarks. Thank you. Over to you, Dr. Krishna.
Thank you, Rajabhai. It was absolutely wonderful. You all, the panelists, the moderator, you behaved more than what I even thought of that this could happen. I'm highly delighted to tell you all that this webinar is now being live watched by 1,248 people. 1248 is the number of logins. So congratulate every one of you over here for this giant step. And now, this could be a little personal, but let the audience also understand. How many amongst you were positive of COVID, diagnosed positive of COVID? Since when it arrived? I'm asking you all here. How many of you since first wave? And how many times? Twice, Nitin bhai, and Vijay once, Raja bhai twice, and Ravi Dosi twice, Pradeep twice. So it seems like everyone is telling like this.
Twice.
Okay, victory. Okay, and so the happiness of taking 8 doses is I was never even once positive.
Oh, great.
Now, how many of your family members you lost? And this is a very personal question. I'm very sorry. Oh, Nitin bhai, last one.
My father-in-law.
Vijay, last one. Father-in-law. Okay, Vijay. Anyone else here?
My dad.
Huh? Oh, your aunt.
My dad died during the first wave, but he did not die of COVID, but he died during the first wave. He died in May.
You know why I'm doing this? Because I want the world to know that they are not the happy faces sitting here. We are like Joker at the circus. Whatever we have at our back, we come out there, we work. That it is our work to take care of you people. Those who are non-medicos also, if you're watching this, you should understand what a doctor has done during the COVID pandemic, and even till now, the war hasn't ended.
Vishnu bhai, someday, on the death of my father-in-law, I had to declare him and then see 20 ventilated patients and then go for cremation. So that was the state of affairs at that time.
Please take a bow, Nitin bhai. Take a bow. Take a bow. Take a bow. This is what everyone should understand from here. This particular panel. The Russia-Ukraine war may end someday, but our war with COVID, we doctors with COVID, we are not sure of that getting ended. At a shorter notice, we don't know. I don't see it as of now. As everybody opined here, it is going to stay with us. Now, my concluding remarks, initially to the panel, I would say it, Raja bhai, other than triangle, it is better here onwards, we look at this COVID as a hexagon. It is not just the agent, host, and environment. It is also agent, host, environment plus vaccination plus SMS plus keeping the medicines in stock. So only this hexagon can beat one corner where the agent is there. This I would feel from my end to tell to this panel. And to everyone over here, the common public or who are watching this, the take home message is very important. Old saying, do not dig for the well to fetch water when your beard is lit on fire. So all of a sudden, when there's a peak in number of cases, when the government enforces a lockdown, being helpless, that economic crisis also starts. If you do not want that to happen, right now you understand that you are living with COVID, which may be at present below threshold, at present could not be harmful, could be invisible to you. Hence, always maintain the discipline of SMS. Those who do not understand SMS, who could be in the audience as common people, it is sanitization, mask, social distancing. This has to be practiced. And if you have not taken any of these vaccine till date, essentially 2 dose, compulsory, mandatory, you take any of them, recommended by the government. Please complete at least 2 doses of vaccine. Those who are vulnerable and at high risk group, please take the precautionary dose. And this is what is essentially required for us to understand what Pradeep said. You live with the COVID. What Ravi said, whether the first wave is over still, that is also countable. As Nitin Bhai told, Raja Bhai told, Vijay told, we are there to live with that. This is my message to the society and those who are watching this webinar on behalf of Chess Council of India. And I thank wholeheartedly everyone here for this wonderful webinar that has happened. Chess Council of India always comes out with something which is beyond the thought of anyone else. Next Thursday, one more blockbuster is coming, which is never done by any other webinar. You must have seen it. You will see it next Thursday. The blockbuster is arriving. Do not forget to log in next Thursday at 8 p.m. for our next webinar live. Thanks to everyone on behalf of Chess Council of India. This is Dr. N.H. Krishna, founder of CCI. Raja Bhai, Vijay Kumar Chennamchetty, Narayana Pradeep, Nitin Abhyankar, and Ravi Dosi Bhai. Thank you so much for your kind presence with your valuable time spared upon. Thank you, one and all.
Thank you. Good night.